we are diving deep into one of the healthcare's most persistent and costly challenges, medication adherence. So we are talking about a problem that affects half of all Americans with chronic conditions, costs our healthcare system roughly about $500 billion annually. It directly impacts the Medicare Advantage Star Ratings.
We know intrinsically by getting medication, adherence in the right place, it has so many spillover effects. It's a force multiplier. Weighting's changed in an ongoing way. Getting medication adherence right has connection to so many other measures that you can't take your foot off the gas. In 2027, all pharmacy-related measures are going to be an even bigger piece of the pie than they are now. Members, oftentimes, the medication wasn't the issue. It was something much deeper. It was something much more significant. And sometimes it's transportation. Sometimes it's that they lack certain healthy foods or they don't like food at all. And so medication is the last thing on their list. So there's a major amount of education that has to take place once you get your foot in the door, and then you have to reinforce it over time. Humans we're stubborn. If you can't connect with them, it doesn't matter what information you're sharing. We found that having a recipe that involves a lot of different modes of communication, be it, digital, as well as telephonic, as well as working with the doctor, we've injected significant amounts of time investment into behavioral science and the importance of, that longitudinal journey. And we recognize that some of the habits and the ways that members need to change don't just happen overnight. They're an ongoing journey.
Healthcare STARcast, where healthcare's true leaders shine. I'm your host, Subbu Ramalingam, and today we are diving deep into one of the healthcare's most persistent and costly challenges, medication adherence. We all go through it. The whole country goes through it. Our relatives, our friends. This is not only a national problem, a global problem, but also a personal problem for many. So we are talking about a problem that affects half of all Americans with chronic conditions, costs our healthcare system roughly about $500 billion annually. It directly impacts the Medicare Advantage Star Ratings, Medicaid population, commercial insurance, ACA, and also determines both quality bonus payments and plan competitiveness for health plans. Today, I'm thrilled to welcome Kempton Presley, the CEO of Adhere Health. Kempton recently stepped into the CEO role early this year, but he's been doing a fantastic job with Adhere. He's been with Adhere since 2012, bringing over a decade of deep experience in medication adherence, analytics, value-based care. Before becoming CEO, Kempton served as a chief strategy officer and chief analytics officer. And that was probably the time, Kempton and I also collaborated, in my health plan back in the day, is leading data science and predictive analytics at that time that powers the Adhere Health platform. Kempton, not only a great industry leader and a good friend as well. Kempton, welcome to the Healthcare STARcast.
Subbu, thank you so much. No, you're wonderful, and it's an honor to be here with you.
Thanks, Kempton. Finally, we made it, right?
That's right. That's right.
It's already December. I'm sure you and your team will be probably so busy closing the year strong and preparing for 2026.
Well, getting to talk with you is just the right infusion of energy and inspiration I need to finish out the year strong. So thanks for the opportunity.
You're so nice. Thank you, Kempton. So you've been at Adhere for about 13 years now. And just in this role with Adhere, and even in the past, different roles, you watched the adherence landscape evolve. And what drew you into the space initially? What keeps you energized about it today?
Sure. So I've worked in the healthcare payer space for about 20 years, and I've always found it to be interesting because my background's a combination of economics, public health, and medical informatics. And so when you look at that Venn diagram and the intersection of those different disciplines, the world that I get to play in now is perfectly suited for it. Ideally, if you figure out the right place in an industry like healthcare, if you find the right domain, it's extremely rewarding because you can do good and do well at the same time, as the cliche goes, but there's a real spirit of innovation to try to improve a broken system and try to help humans be the best versions of themselves. And so medication adherence is so interesting to me because it not only has such an impact on the entire landscape of an individual's health, and it has so many points of tangent to cutting edge innovation and the life sciences and biotech, et cetera. But it's also a really interesting proxy as a reflection of human behavior and the choices that we make in an ongoing way. There's no other part of the healthcare continuum that has so many different connection points with people and is such a consistent reflection of their daily choices.
That's awesome. So when you were talking about it, you think about Steve Jobs' speech, right? You can always connect the dots only after, right? So all the different skills that you have and the leadership, all, coming together to solve a critical problem. And as you mentioned, it's multidimensional and it needs innovation to solve it with different skill sets. With that strong foundation, Kempton, as I was actually preparing for this conversation, I was also looking at some of the data around it, right? Obviously, we know medication adherence is a sort of huge problem, but I was actually really, as I was reading through it, some of the research materials, I was stunned by some of the numbers. If you look at the problem from a public health perspective, based on data published, like peer-reviewed journals, validated by Pharmacy Quality Alliance, medication non-adherence contributes to about over $500 billion in avoidable healthcare costs, right? These are things that are in control, per se, annually in the United States. And then about 125,000 preventable deaths each year. That's just, validated, counted. There are probably many more that are not accounted, directly, but it's actually based on medication adherence. And because of treatment failures, and leads to nearly 10% of all hospitalizations. 10%. Huge driver of cost, obviously. And then about the American Journal of Managed Care found that patients who missed even just one adherence measure experienced 12 to 26% higher all-cause healthcare utilization. All right, that's like $4 trillion in terms of healthcare costs. Anyway, I'm just putting this in context, to kind of move, through our conversation here, right? I know you're also really closely associated with the Pharmacy Quality Alliance, where you also speak there. So for listeners who are new to this, Pharmacy Quality Alliance develops the adherence measures that CMS, Center for Medicaid and Medicaid Services, uses in Star Ratings as an example. They set the standards. They work with stakeholders like Kempton and others and industry folks. And these are triple-rated measures. We'll go into that, from a Medicare standpoint. So Kempton, when you look at these statistics that we talked about, right, and you work with, multiple health plans, partners, where do you see the biggest gaps in how, as a healthcare ecosystem currently, addressing the problem? Where do you see the biggest gap is? I know it's a loaded question, right? We'll start with that.
It's a good question. I think oftentimes adherence is such an important proxy and is such an important lens into somebody's entire healthcare experience. And so when we think about things like the Medicare Star Ratings, which you just touched on, that are informed by PQA and enforced by CMS, there are so many different aspects of the ways in which medication adherence touches all the different measures that are in there. And so for people that don't know about the Medicare Advantage Star Rating system, it's like a really complicated gamified GPA, right? That each plan gets to use and that they get measured on a 1 to 5 rating. And so the interesting thing about medication adherence is that there are certain measures that are dedicated to medication adherence, but then there are also so many other measures that are affected by medication adherence. So if you're taking your meds, Subbu, as you pointed out, so many good stats, if you're taking your meds the right way, it can lead to so many good outcomes in terms of metabolic condition control, blood pressure, diabetes control, all things that are measured by that system. If you're taking them the wrong way, it can lead to all sorts of different catastrophic events. You mentioned the 125,000 avoidable fatalities. There's measures like COB, which is opioid and benzodiazepine overlaps. There's measures like anticholinergic medications where other overlaps. So when medication's used the right way, it can do so much good, but when it's used inappropriately or suboptimally, it can take your health the other direction. And so one of the reasons that our company came together 20 years ago was unfortunately due to a medication error. Our founder's brother was a pharmacist and he died of a medication error, which was horribly ironic and led to the creation of this company to be able to solve for these medication issues. A lot to consider there in terms of impact.
Yeah. Yeah, I didn't know about the actual founding story, which we'll get into it a little bit more, which is very not shocking, but also sad. We see these errors going on. Obviously, as you touched on, the ecosystem in terms of people who are involved in this is pretty big, right? So let's start there a little bit, right? Who's involved beyond the patient or the member, in this, right? So it's a complex problem. So the ecosystem needs to solve it. Obviously, the patient is the center, but adherence really requires stakeholders, families, health plan, health system. Walk us through the key players that you work with, right? So how the incentive align and how there are conflicts sometimes because the doctor may think about it differently than someone else, and there's access. So about the critical disconnect we see, right? Non-adherence, where for 30% of patients, never even fill the initial prescription. There's you talked about the behavioral, part of it. The physician writes it, thinks that they've done their job, right? It's not even filled, or like even if it's filled, not taken. So break it down for us. Who are the different stakeholders, typical stakeholders, and who are the different stakeholders that are highly underutilized in solving this problem?
For sure. No, I'm so glad you brought that up because it takes a lot of cohesion within the care team itself. And as you mentioned, that care team obviously involves the patient, but it involves their family. It involves their entire community. I can get into that momentarily. It involves their doctor or the many doctors that are involved in their care, or the other providers, nurses, other types of clinicians. It involves the pharmacy itself where they get their medications. Oftentimes, we collect so much data when we're talking to patients, and we get anecdotes about all those different constituents. So, hey, why haven't you been able to go pick up your medication? Well, I need a new prescription from my doctor, or I need to talk to my doctor about side effects. So there's a patient doctor question. And then there's also this, feedback that we'll get that they'll say, hey, my pharmacy hasn't filled it yet, or, they didn't ever get the prescription, or I can't get to my pharmacy. I have an access issue, I have a transportation barrier. And so that brings in the pharmacy patient connection. Then you find other instances where someone says, hey, look, my spouse is the one who helps me navigate all my medications. They make sure I take them every day. My spouse is ill, or they've been in the hospital, and all of a sudden my support network has changed dramatically. And so you think about that constituent. And then you think about other things, like there's also government components, there's policy, there's all sorts of different aspects of how coverage gets laid out from a policy standpoint. And then there's pharma. There's all sorts of new medications coming on the market. So you bring in all those different pieces, and medication adherence is affected by all of them. And so it really involves, mapping out the right approaches through behavioral design and other things to ensure you're accounting for those different constituents in this greater system.
Yeah, that's a good synopsis. And I think one of the things, I didn't think about, like you mentioned, is a good point, is new drugs coming out, right? What do you do with it? So it's a complex web in the United States. Excuse me. So it really requires a cohesive strategy to really impact the adherence problem here. Let's shift to the business case a little bit, right? So if I'm a health plan executive listening to this, right? The question is always, what's the ROI? We've been on the table together.
Yeah.
Yeah. What's the ROI? Is it working? So there's the Medicare Star Ratings system. That's actually a direct connection to adherence. What do you see from an adherence standpoint? What are the different components of ROI you deliver as part of Adhere. Product, it's not only the product and the service that you bundle up for health plan executives.
Sure. No, I'm so glad you brought that up because, and just as a shout out to you, one of the things I loved about working with Subbu is you always had a wonderful sense of the connection between the clinical side and the economic side. And that's so important in terms of the sustainability of various programs and, working through your partnerships, making sure those indicators are good in terms of how you're doing with the various measures of ROI. So we think about ROI in two major ways. So one is, there are all these quality measures that we talked about earlier, and plans have to be able to perform in the context of those quality measures. We talked about star ratings, there are Medicaid measures, there are HEDIS values, there are exchange metrics that matter. Those are all leading indicators, but the performance with those leading indicators is important for health plans and other constituents and for providers, because it leads to, in some cases, bonuses. In some cases, it involves penalty avoidance. So there are sort of economics there associated with the short-term indicators. So that's one side of the curve. The other side of the curve is all of these measures, especially in medication adherence, are designed for ultimate health improvement and cost containment. Right. And so if you move beyond the leading indicators, we look at total cost containment through medication adherence through three major lenses. It's sort of the short, near, and long-term consideration. The short term is saying, okay, if we get somebody on the right medications, if we get them off of duplicate medications, which happens quite often, if we get them on a lower cost medication, you hear a brand, a generic, that's a short-term savings. That happens, month one. Near term are more of those acute events. And Subbu, you mentioned, hospitalizations and ER visits and other things. Those are things that if I'm on two medications that could harm me, I'm very likely to have an unexpected event. And so you can show by getting members off of conflicting medications, by getting them off of aggressive or dangerous treatments, that can have near-term impact. That's your quarterly, 6-month impact, right? Within year, let's say. So you got short-term, which is medication changes, which is, immediate pharma cost reduction. You got near-term, which is acute issues like ER visits. And then you've got the third, which is long-term. And that has a longer tail on it. So by getting somebody to take their statin year over year over year, you may not avoid that cardiovascular event year one. It may be something that you're avoiding year 3, right? And so because of that, and when you're dealing with healthcare payers, that ROI conversation can be complex, right? If you've got a payer that's dealing with quarterly earnings, they're saying, hey, it's hard for us to get behind something that has an ROI with such a long tail. So you got to justify your existence with those other short-term measures. And then ideally, the longer-term cost control is icing on the cake, if that makes any sense. So that's how we think about it all.
No, that's well laid out, Kempton. I think a few of the industry colleagues, we were talking about bending the cost curve, right? So too often the cost component or the impact on medication adherence and related stuff is often thought about it down the line as the icing of the cake, right? So thankfully, there are some, although it's not perfect, there are some good quality measures that actually is helping the costs, right, in a way, from a short-term perspective. But I think definitely on another conversation, we need to jump into the cost side even more with, broader industry feedback, because I think based on the numbers, it's such a low-hanging fruit, so to speak, to bend the cost curve. We just, as an industry, I think, I know you guys have, you talked about the sophistication and measuring the cost, down the line. But at the same time, I think as an industry, we just need to get behind how measuring the cost impacts on a regular basis, not an after effect, right? It's complex at the same time, right?
It is, absolutely. And again, there are people that have different time pressures and trying to balance those and then trying to quantify the avoidance of certain events. It all matters, right? So your points are absolutely spot on.
So Kempton, on the short-term impacts, right? So recording this conversation on December 2nd, right? Last week, just before Thanksgiving, and even before that, a freight train of so many CMS policies dropped, right? Including the advance notice, changes to the star ratings. For context, medication adherence measures and other pharmacy measures that Kempton also talked about. It's part of the star rating system for Medicare Advantage. So there are 3 triple weighted measures that are going to be single weighted for just 1 year, and it'll come back to triple weighted again. And the reward factor, which is the bonus factor that has existed, which was supposed to be stopped, and the excellent healthy outcomes for all, or it used to be called the Health Equity Index, was supposed to go live, and that's on a pause. So the reward factor continues. So there are lots of different changes that are happening, and you guys must be so busy in working with the clients to push through. As we think about this, Kempton, the triple weighted medication adherence measures, for health plans, I've been there, right? So I've worked with plans now, this is a big one. So as you think about transitioning into 2026, with that being single weighted, what's your general approach with your customers? How is Adhere going a little bit more proactive to make sure the health plans continue their performance, not taking the brakes off, and be ready even for, when the triple weighted measures come back later?
For sure. No, it's a great question. And as you mentioned, never a dull moment, right? And so we've sought to design programs that will be pursuing a North Star that is agnostic to the shifting sands of regulation. So we know intrinsically by getting medication, adherence in the right place, it has so many spillover effects. It's a force multiplier, as we talked about. So we know that weightings change and an ongoing way, but we also know that getting medication adherence right has connection to so many other measures that you can't take your foot off the gas. We also know that medication adherence is not just a short-term journey. So we've injected significant amounts of time investment into behavioral science and the importance of that longitudinal journey. And we recognize that some of the habits and the ways that members need to change don't just happen overnight. They're an ongoing journey. And so there is a temptation at times to say, okay, we need to shift our focus over here because this doesn't have the same short-term gravity. But the reality is that momentum, quality is all about momentum. And you've got to keep that momentum going. Because we know that in 2027, all pharmacy-related measures are going to be an even bigger piece of the pie than they are now, right? We know certain administrative things are supposed to be going away. So your medication adherence is actually going to have a relatively larger impact than it does even in 2025. And so our position is keep going, keep running after these things, keep driving the behavior change, keep embracing the impact of the force multiplier as it affects blood pressure, diabetes measures, all the different companions to adherence, and embrace also patient safety measures. Those are 2 that involve getting members off of dangerous medications or dangerous combinations. And so that's another kind of aspect of the adherence continuum that's really important that can catch plans off guard if they don't manage them. So that's our sort of position on it.
That's well said. And quality is all about momentum. That's a really good one, right? It's we're December, and it's important if health plan leaders, health systems, others are listening. Momentum to begin early next year, as Kempton mentioned, is going to be very, very critical. And well said, Anna Kempton, on the momentum piece and your approach. I think they've established what the problem is, right? I think what the general ROI is, what's at stake, especially in the context of Medicare Advantage. Obviously, this applies to state Medicaid, ACA, you name it. But Medicare Advantage, there's more incentives, to it. Let's talk about some solutions, right? When plans come to you saying we need to improve our adherence performance, I was one of them back in the day, a few years ago.
Thank you.
And continue to do that, right? It's always a challenge. We're always looking at, different solutions. What's available in the market today, right? Plans are doing their own thing, whether it's bringing all the different players together, the stakeholders that you talked about, pharmacy, point of care, outreach to physicians, outreach to members, outreach to caregivers, etc. When someone is choosing between different point solutions, That also includes probably food and Medicaid, food and social determinants factors as well. No amount of reminder calls was fix some barriers, right? There's some barrier out there. Like you could do 10 faxes, 20 phone calls. It's not, it's waste, right? So given that I see a lot of these solutions out there, what's your differentiator? What's Adhere's differentiator in the market?
So a couple things. You made a very good point, which is connecting with the member and or their care team is step one. And if you can't connect with them, it doesn't matter what information you're sharing because you're not even really in the door with them. So we found that having a recipe that involves a lot of different modes of communication, be it digital as well as telephonic, as well as working with the doctor, as well as pushing data into EHR, as well as other types. I mean, even snail mail in certain instances resonates with a member. And so if we find that right combination and that right recipe for connection for certain populations, ideally we're getting that combination down to the member level and having an N of one, where we know the best ways based on member propensity, based on psychosocial issues, based on zip code, the best ways to connect with people. And then when we connect it with people, it's about much more than medication adherence. And we found this out way before there was so much focus on SDOH or HEI, as you mentioned, or all the different types of programs there. We found that members, oftentimes, the medication wasn't the issue. It was something much deeper. It was something much more significant. And that's why, again, our investments with behavioral science and with Chandra Osborne, our doctor of behavioral science, being able to get into the why behind members not going and getting their medications. And sometimes it's transportation. Sometimes it's that they lack certain healthy foods or they don't like food at all. And so medication is the last thing on their list. In other cases, there's something much deeper in terms of fatalism. There's a perception that, based on family history or other things, that they may just not believe that the medication is going to help them, or their current condition lacks any kind of pain. It's symptomless. Yet when they take the meds, there's side effects. So the cost benefit doesn't seem there. So there's a major amount of education that has to take place once you get your foot in the door, and then you have to reinforce it over time. And so it's not a one and done type of change. Humans we're stubborn, right? And so being able to make sure that we reinforce certain behaviors, and then per your point earlier, that we're also in parallel making sure the doc is on board, making sure the pharmacy has the medication ready, and removing any more barriers to getting that med. And that's why, again, it's so important to have that longitudinal situation going, because adherence is very much more a marathon and not a sprint.
Yeah. Yeah. So Kempton, talk to me more about the predictive analytics of the behavioral health component, right? So there's the intervention part, but there's also like the right intervention based on data and also the behavioral health component. How are you broadly identifying which members need intervention, and how is that different from what plans can do on their own with their own data? Plans have their internal algorithms, or they have a little bit of social determinants data, often not utilized well, but typically they would have real time compared to the vendors. So what's different, and how is your approach? And this goes back to the ROI conversation, but I think this is where the secret sauce, right? This is where the real kind of meat of making an impact with a lower cost intervention, comes in, right? Really curious, because I think I see a lot of different solutions around this, right? I think there are people who are out there selling how AI can solve everything. So it's really not true. It requires a lot of thoughtful intervention. So would love to hear more.
No, it's a great question. The first part of my answer may seem more simple than it should, but adherence math, or the calculus of the calendar, is important, right? And so we know there's a certain amount of leverage that happens in the adherence calculation between a member's first and second fill. And for folks on the line, that's how you qualify for adherence. You have to have 2 fills. So you can understand a lot about a person based on the space between their first and second fills. And we call it kind of minding the gap, because it's kind of like a bad interest rate or a loan that gets out of control versus an investment that does well, right? If you start out in a strong place and you mind that gap the right way between your first and second fill, you're able to have much more room in the calendar to be able to have good behavior and in turn stay at the certain adherence rates that you need to be at. Versus if you start out and you qualify for one of the measures and you're already underwater in terms of you missed a lot of days, then you're having to work the whole rest of the year to try to catch up. And so it's really an important and compounding impact. So that all said, we have to think about how we're outreaching to someone and anticipating whether they're going to get, for example, their second fill, and how that's going to happen in terms of towards the end of the year. Some people have been in their first fill all year long, and they may get their second fill and become guaranteed non-adherent right away. So that math is important, right? But that's really more around the adherence game. That's more around like performing well in the measure. What you're really getting to, which is the right question, is how do you connect with members? How are you anticipating their needs? And we found that if we can reach out to people at the right time when they can go get another fill, if we can reach out to their doctor and use their doctor to be able to message them and restore that relationship, that also is another way to connect. If we can help them somehow by arranging, the connection with their transportation benefit, or making sure that we're reporting back to the plan where they have affordability issues, like that establishes some rapport that we can play on and improve their health the rest of the year. So those are a few of the things. We do want to get better and better in terms of some of the things you mentioned on, knowing exactly the types of communications that someone wants to receive, right? Everybody has different preferences. And we found that the senior population who used to not really use things like texting or other digital capabilities, that sure has changed. I mean, I think you would probably say the same thing in the last 15, 20 years since we've been in this star ratings world, where Medicare Advantage members very much use digital. And so making sure we're using it the right way to engage patients and calling in and reaching out to them at the right time.
Yeah. No, it's awesome. I think more and more people, it's like there's a stat is amazing in terms of like the digital use, but actually even we see our loved ones or friends who have Medicare Advantage, they're using it as just like, validates it even more, right? They're out there
Absolutely
on their Facebook, some of them getting into LinkedIn and also Instagram in a bit. So I think it's definitely a huge opportunity to leverage that appropriately. So Kempton, you've done a lot of work on this, a lot of thoughtfulness, and got an incredible team. Let's talk about the actual impact, right? So there are some case studies out there publicly that, even in your website. I'd love to hear some planned success stories, but also some real kind of human stories, if we can share on the impacts Adhere's team, along with a plan partner, has done to the population.
Sure. No, so we like to look at it both from as you pointed out earlier, kind of a personalized standpoint where we understand and we surface case studies that reflect the experiences of patients and their loved ones and how we're able to navigate the healthcare system with them and through their different life events. And so we'll oftentimes showcase those very early on so that our plan partners can have a real sense of the humans behind each of the stats. And then we'll show the stats and we'll say, okay, look, here's how we've been able to move the needle and been able to improve the portion of members that eclipsed 80% in terms of their proportion days covered. Here's the number of members that we were able to get off of opioid or benzo combination. And we were able to keep them off of those medications for a certain amount of time, not only to make sure that they're improving in their star measures, but also to avoid some of those near-term catastrophic events that we were talking about earlier. And so being able to show some of those intermediate statistics is really valuable. One of the things that we did early on is we configured our model so we go at risk and we only get paid if there are member measures that are improved. So we would only get paid if a member takes their meds for 80% of the year, and we would get paid based on leading indicators. And then we would get to keep that payment if the member ended the year adherent. And so going at risk at the atomic level makes sure that our incentives are aligned with the different types of incentives that our plan partners have. And so that translates in aggregate to improvements from, at full star rating levels. Now, it's hard right now because the curve or the thresholds continue to get harder, right? And so there's a lot of changes happening there. And in many cases, by improving year to year to year, some plans only can stay at a certain star level and they need to keep improving. So you got to overshoot the curve. And so that involves going after those really tough to reach members and working through them and trying to also maintain members that are doing okay but aren't guaranteed. So those are the types of things we consider. One thing I will say is that next year, adherence is moving to kind of a risk-adjusted level, which means low-income subsidy and disabled and dual SNP populations are going to get ranked differently than their non-LIS, dual SNP, non-disabled populations. And so that affects both of those plans and their competition very differently.
Yeah, cool stuff. Lots to look forward to with the changes, right? I think this is where like the behavioral, the atomic level data analytics in the precision is going to be even more beneficial, I think, because like, as you said, the traditional, let's call it the traditional medication adherence measures, there's also numbers game in it, right? So there's like the fill rates and all that stuff. But like when you add the risk factors, that actually you need precision solution to kind of handle that for each of these plan. Technology data side of things, Kempton, something close to my heart. I know your data analytics and health economics guy at heart as well. Everyone in healthcare, if it's not AI is not in the banner, you'll be surprised, right? So it's a tough one, especially in healthcare. I'm an optimist, and I feel like there are certain things right now AI can solve, but it's a long way to go in terms of really impacting healthcare from an outcome standpoint. But anyway, you've been doing predictive analytics for years, right? The AI models are changing like the predictive analytics and machine learning landscape a little bit more. You can deploy faster. You can actually see how the model is working and all that stuff, right? What role AI plays a role in Adhere's roadmap? Importantly, like how are you guys thinking about not AI replacing, but like augmenting humans and clinicians to really do better care and, for the health of the population?
Sure. No, thank you for bringing this up. And again, the class I teach at Vanderbilt in the data science group is about teamwork and the importance of humans in the whole data science landscape. So, it's consistent with Adhere Health, where we think that all of this has to happen with recognition of the human spark. That's so critical, right? Connectivity and the fact that human beings can sniff out when someone's a robot versus when it's a real human.
Yeah.
The use cases that are most exciting to us are those areas where through AI, you can build scale, you can remove some of the administrative burdens that allow more clinical people and more relational folks to be able to practice at the top of their license and touch and connect with more people. We know that AI does help, take over and replace many of the kind of administrative tasks and some of the dot connections, per your point about Steve Jobs earlier. There's certain low-level dot connections that if you can move quickly in terms of your front-end insights, where your models are looking for all the different types of connections and the ways that people, their propensities, and how they're more likely to move and respond, then that allows quicker decision-making for the clinician. That allows for being able to do less, be able to do more with less because there's not as much paperwork. Being able to overlay these clinical models and these AI models on all the free text notes and say, what does that surface up? What are the things that we couldn't see as humans as quickly? And so being able to use AI for that, being able to use AI for training and being able to show various types of outreach personnel and care navigators, the types of nuances that are most effective with patients, right? And so AI allows for the synthesis of all the data to be able to say that and be able to inform and provide decision support that allows us to scale and drive more impact. Now, I say all this, Subbu, and you get this that we have the advantage of having many, many different compliance departments that we're working with, right? And so we have to go at the same pace that our plans want to go at because everyone has different points of view, and there's not a common standard yet on AI use, right? There's not a consistent framework like a HIPAA or high trust yet that fits into this payer landscape. Those things are coming about for sure. Right now, as a result, it means that many compliance teams are overly conservative. And understandably so, because there's been a lot of difficult press about pre-auth and rationing of care. But we got to get kind of more specific in the use cases so that we can advance and innovate together with our plan partners.
Yeah,
Sorry, excited
totally.
about.
Yeah, totally. No, this is an exciting, it's like, the possibilities are immense and to your point, like the compliance stuff and the trust, right? Also like the trust, like a trust with what happens with it. It's interesting. I was in a conversation on one of the advisory boards in the CHI, Coalition of Healthcare AI, right?
Yeah,
All trying to figure out, okay, what are the different use cases, industry feedback, etc. It's a complex noodle of different opinions, and we have to come to a common standard, to your point. So it's going to take some more time. But I think it's worth going through that, because I do see, as you pointed out, the technology is there, right? The technology is there, the use case that you talked about. But I'm being optimistic, but at the same time, there's the data summarization and synthesis part, right? And the model calibration, and there's the care navigation part. So as you sit here, end of 2026, I think, let's shift to 2030, next to 3 to 5 years, right? So what is your vision from an adherence standpoint and capability standpoint, right? So assuming there are barriers in compliance is getting solved, etc. What's your vision for your company evolution?
as noted earlier, trying to balance the risk aversion that may exist, right, in the market, but knowing that that's going to change. And we don't want to be caught flat-footed when it does. It's kind of like what we were talking about with digital with seniors. Everyone was very resistant about using digital tools with seniors, and all of a sudden they weren't. And the question was, where are you with this, right? And so we want to be ahead of the game. And here's the thing, is that pharma alone is poised to change dramatically over the next 5 years. I mean, there's speculation that the next 5-10 years are going to be the equivalent of the last 100 in terms of some of the scientific advancement. And so we got to be like, our main job as a company is education and information. And with information changing so rapidly, we have to find ways to synthesize the best information at the right times and do that in the context of new communities. So will people have caregivers that are robotic? Will everyone have transportation that is, will the self-driving aspect be able to make connectivity easier for certain patients? What's going to be happening with, payment models at that point? My sense is that value-based care is still going to be here. There'll just be different ways to take on risk. And so, as you can tell, I've got different questions, but we're trying to get, part of the way we're positioning for it, Subbu, is to make sure that all of our data models are as solid as possible, and make sure our kind of human design through people like Chandra Osborne and other members of the team who are designing the best workflows, that they're as sound as they can be, so that when you overlay technology on them, you're automating really good things. Your intrinsic, your DNA is sound, and then it can scale. And so that allows us to get those things right as the tech continues to evolve and as the market around us continues to evolve. If you've got ideas, we'll always take them from you, because you're thinking about it in a good
We'll
way.
always be talking, right? So this is going to be an exciting time, and thank you for sharing that, Kempton. This has been an incredibly rich conversation, starting with the problem of like 500 billion. We obviously touched on the star rating side, the social determinants barriers, your company differentiator, and you as a professional and a person, your journey into this, and last but not the least, right, the technology and the how AI and other things can evolve, and really, it's a human problem. Obviously, there's the medication and the pharmacy, there's the upstream stuff, but ultimately adherence is like a human problem, right? And cool that you guys have a whole behavioral health component with Chandra Osborne on your team. So thank you for your time today, Kempton. Any final thoughts for my viewers, who are trying really hard, especially down the health plan side, finishing the year strong? They're trying to think about 2026. Any final thoughts from your side?
Well, I would say, Subbu, all of our conversations are rich. I'm just glad this one was recorded, right?
Yeah.
But I think, what I would say is that making sure all these models are locked in, independent of any of the technology, that the workflows and the ways that folks are interfacing with humans and the way that they're leveraging their clinical staff, you know, yes, it's going to change, but you got to get it right in the fundamental way. And as we discussed, having that momentum year over year is going to be critical, and it's going to differentiate those who succeed versus those who fall short. Excited to be able to keep the dialogue going as we all figure it out.
Perfect. Thank you for that, Kempton. So, Kempton, obviously, you are in LinkedIn, your company, Adhere Health website. Where can people see you in conferences in the next few months?
Yep, going to be
Where
at
are
the
you going?
Fierce Healthcare Conference this week. I'm going to be out in LA at 5 in early 2026. Some of the different RISE conferences, which are always great in health. But no, I'd love to connect, and LinkedIn and other pathways are always great. And Subbu, I know that you and I will stay in touch on all this stuff too.
Sounds good. Thank you, Kempton.
Thank you. Great to be here.